Good afternoon. Thank you, Dr. Hakim, and thank you, Laura, and also the entire EDS community. I wanted to share with you sort of a little bit of my world. I did 2 fellowships, orthopedic and peripheral nerve. My mentor, Lee Dellin, just recently retired from the practice of peripheral nerve surgery, so I'm charged into educating and stimulating younger, newer peripheral nerve surgeons to train in the field and also get excited about helping EDS patients with nerve compression and nerve injury. I'm in Washington, D.C. in a private practice called Nerve, Bone, and Joint Institute. Thank you. So today we're going to talk about an approach in diagnosing EDS patients with nerve compression, nerve injury. When we look at the history that's been published in the EDS literature, Dr. Henderson's et al. Team has discussed Chiari malformations, atlantoaxial instability, craniocervical instability, in addition to kyphosis, tethered cord, and movement disorders and some of the neuromuscular features, and Tarlos cysts. However, in this manuscript, we'll see that there's not much mentioned in peripheral nerve. And as Dr. Hakim mentioned, I think it's really important for us to take a moment and just open our mind into looking at how can a peripheral nerve affect our EDS patients. Dr. Chopra, in another EDS manuscript, discusses pain management approaches and joint mobility, joint stability, being prone to injury, prior surgery, and muscle pain with a multi-tiered approach, including physiotherapy, cognitive behavioral therapy, medication and devices, and looking at evaluation of fibromyalgia and low-dose naltrexone. In some of the patients that we look at, joint pain is a common complaint in our EDS patients. What if that perceived pain originates from injured joint sensory nerves? I had a publication with Dawn Laporte at Hopkins and looking at the sensory nerves to the thumb CMC joint. And we dissected the nerves and proposed some treatment options and doing a partial joint denervation. It also implies that these nerves exist and can be identified with surgical loupes or a microscope. And also implies that the pain can be stopped and joint function can be preserved. When we look at our EDS patients, no 2 patients are the same. Just like our clinical patients, no 2 patients are the same. We'll see that some of them have a higher presentation with joint instability, others with dysautonomia and headaches. Going to the microstructure of a nerve, it's almost that I compare this to, our CAD cables or telephone or cable lines where you have numerous fascicles or numerous electrical wires. And then looking at the outside of that wire, we call that the epineurium. And then coming in within the fascicles, the perineurium, and looking at the endoneurium. And looking at the motor origin, this is going to be our anterior horn, and the dorsal root ganglion being the sensory component. Fascicles are basically a bundle of myelinated and non-myelinated fibers, and the non-myelinated fibers are adjacent to the myelinated fibers, and they're associated with one Schwann cell. When we talk about the classification system, Dr. Seddon and Sunderland, they've talked and described this in the literature, and we always quiz our surgical residents and hand fellows exactly where we are in this spectrum. I think it's important that we have an application to it. So our first degree is going to be the conduction block, and that's due to demyelination. Here, there's no muscle wasting. Patients usually complain of pain and proprioception issues, in addition to the interoception that was presented earlier. And the recovery is within a few months. Going to second and third degree, here, axonomesis, there's Wallerian degeneration, and then progressing to endoneurium damage. There's a spectrum here. Here we have muscle wasting, pain, and complete motor sensory and sympathetic function loss. Then we go into the more severe fourth and fifth degrees that I'll present in cases as neuromesis, where the nerve is filled with scar, and then it also can have nerve transection. Just took care of a patient that had a complex knee dislocation with the distal sciatic and a peroneal nerve injured that we had to reconstruct. So here the patient has no pain, there's muscle wasting, surgical intervention is usually indicated, and here we're thinking of nerve decompression, possible nerve reconstruction, and consideration of distal nerve transfers and tendon transfers. Dr. McKinnon, one of our leaders in the Peripheral Nerve Society, here she talks about nerves being in a container. So this is, there's mechanical and there's blood flow issues that are associated with that container. With the 43 pairs of peripheral nerves, there's more than 100 different entrapment neuropathies. And as, again, Dr. Kim just mentioned, EDS patients, I strongly believe, are at higher risk for nerve entrapment. So we have to continue to think about pain, numbness, and tingling as it relates to potential underlying nerve entrapment. So for the median nerve at the wrist or the median nerve in the forearm, some considerations are pain that starts at the volar wrist, so starting here, radiating to the shoulder, or going into the thumb, index, long, or ring finger, or a combination of those. We have numbness, we mentioned. In the Hand Society, we talk about something called nocturnal paresthesias, and how many nights, even with nighttime splinting, are patients complaining of that. The more severe nerve compression, you're going to have more nights out of the week with the nocturnal paresthesias. Tingling, usually you're going to have that in the same distribution that follows the median nerve territory. Weakness, there's about 3 muscles in the hand: opposition, abduction, and flexion. And so I think it's really important when we're evaluating a patient with median nerve compression, we have to look at their median nerve function proximally, which gives us the ability to make an OK sign. Separately, the ability to oppose, abduct, and flex, which is the median motor branch. In this article, it talks about entrapment neuropathies and polyneuropathies in EDS patients. And here, I think it's really important that this study found that there were some discrepancies or inconsistencies if we just purely rely on an EMG nerve conduction study. And we should also keep our minds open. First, it's the history, then the physical exam, then your ancillary studies, which include electrodiagnostics, nerve ultrasound, potentially MR neurography. So this is here. Again, going to the clinical evaluation, I think the most important high point here is listening to the patient. And I can't highlight that enough. We gotta sit down and take extra time, especially with our EDS patients, allocate more time in the schedule, and ensure that you're actually listening to their complaints. Because if we don't listen to their complaints, we'll miss the entire boat. If we rely on the medical records that is maybe scant or maybe voluminous, we're still missing what the patient actually is there to see you for. So here we're mandated in identifying all sites of nerve injury, detecting the underlying musculoskeletal disorder, completing a motor and sensory exam that could determine the severity of our nerve injury, and creating a very comprehensive treatment plan. Our pain questionnaire, I think there's been an evolution in our pain questionnaire. Before, we used to discuss pain severity of 5 out of 10. In surgery, we want these binary answers to move quickly. But with our EDS patients, we need more descriptives. We need to understand where exactly is their pain, where is it radiating to, what's going on. And these descriptives are very important. And in some of the questionnaires that we look at, when there's 2 or more positive categories, we also involve our mental health team as well, because we want to holistically take care of our patient. On physical exam, the article on the right will discuss validity of a Tinel sign. And just in short, when we look at a Tinel sign, we're going to use our long finger or index finger and we're going to be tapping on an anatomic narrowing. So if we're evaluating someone for median nerve compression, I suggest, and I'll love to, after the talk, share with you how we do it. So we're evaluating here, we're going to evaluate in the forearm, we're going to evaluate in the plexus, and evaluate other areas. This study right here shows that the Tinel sign was discriminative and valid for diagnosing tibial nerve entrapment, at the ankle, called tarsal tunnel syndrome. We also have sensory motor Tinel provocative vibration, temperature, and reflexes. Some of the other diagnostic modalities that we utilize is imaging. Okay, starting from a basic X-ray. In our clinic, we have live fluoroscopy, so we're looking for instability. We're not looking for a static wrist image or a static ankle or hip image. We're doing it dynamically to see, is it subluxing? Is it dislocated? Is it coming in and out of the joint, right? Next, we're using musculoskeletal ultrasound. I'd use this on a daily basis. Then duplex with our vascular colleagues if we're looking at neurogenic or vascogenic thoracic outlet syndrome. MR neurography with Dr. Chabra when I was a fellow in Baltimore. Lots of advances there in looking at the ultrastructure of nerves and the surrounding tissue of nerves. This article talks about ultrasound as a complement, examining the cross-sectional area, echogenicity, morphology of fascicles, thickness of the epineurium. In CIDP, we're looking at multifocal enlargement. Diabetic patients, we're looking at isolated nerve enlargement. With respect to electrodiagnostics, there are classic EMGs, and then there's going to be inching studies. And I think it's really important that there's a spectrum again here on a classic EMG. In one study, patients with carpal tunnel syndrome, 13 of those patients had a normal EMG, but they were clinically positive. Then going to the inching study, out of the 115 carpal tunnel patients, the inching study captured 73% of those patients. Additional diagnostics, Dr. Saperstein has talked about the Q-SART sweat testing. We think about skin biopsies, nerve biopsies, if we think there's a vasculitic component or amyloidosis. Lab tests, again, it's going to be an extension of the history. If we're concerned about an acquired or hereditary etiology, we're going to involve and obtain more electrodiagnostics. So again, we don't jump into the operating room. We think about all non-operative modalities, including our expert physical therapist. Susan just was mentioning she's teaching a whole echo class and therapists from Korea, from all around the world. I mean, that's amazing. That's the spirit of EDS and the society. And looking at all non-operative options of neurogliding, postural kinematics, all the conversations that we had before. Minimally invasive, we think of regenerative work. We use patient's plasma, paraneural PRP. I do that in the office. We do microfractured fat, bone marrow. These are all non-operative modalities. So nowadays, when you see the nerve and hand surgeons, we're not in the operating room. We're in clinic more than the operating room, because we're trying our best to optimize these patients. So when we live with chronic pain, it's hard, but more importantly, it's dealing with those people who don't care or understand or listen. Jumping into, this is some surgical cases. Please don't mind the gross anatomy. It's supposed to be beautiful anatomy, but this is an EDS patient, actually. I was seeing patients in Dubai with Dr. Dellin going back and forth every year. We fixed his wrist fracture in the States, but then ultimately he was working as an expat in Dubai. He had central wrist pain that we evaluated two of the sensory nerves, anterior rossus nerve and posterior rossus nerve. At that time, he failed all non-operative modalities. We did a partial wrist denervation. And this was described initially by Dr. Wilhelm as a total wrist denervation. Dr. Dellin popularized it as a selective denervation. This is a patient that was a baker that had a mutilating injury to the hand. And in the operating room, we did sensory nerve transfers because she had phantom limb pain at her original index metacarpal head, that everything that touched it, she would just have this electric shock. After the sensory nerve procedure that I performed, the phantom limb pain was treated successfully. I got lucky there, right? Third case is a penetrating wound to the plexus. And again, this is just important for us to understand. This is the more invasive variety. Our EDS patients have traction injuries to the brachial plexus. This is just showing you an operative case that we had to reconstruct the medial cord. This is a recent patient from North Carolina that initially had a broken bone here at the humerus, didn't have it treated right away, had it later, had a non-union surgery with plating and developed a wrist drop. So we had an 11-hour surgery that I reconstructed his radial nerve and then distally used branches of the median nerve as nerve transfers, and I did a tendon transfer to keep his wrist in functional position. Up to now, his function, he has differential finger gliding, which again, I'm very fortunate of. So that's 2 of 2 being lucky. All the other ones, not that lucky, right? So this is the operative photos of this case that I just discussed. And then again, we're thinking in different parts of the literature, it'll suggest what the incidence is. But again, we have to be thinking about nerve compression in our patients. If 1 of 4 have hypermobile syndromes, we have to be thinking about nerve compression in the entire body. So again, pain, numbness, and tingling, we have to really go back to our detailed history and physical. And then thinking about exhausting all the non-operative. And all the speakers today did a beautiful job throughout this seminar and course and conference. So just going backward, Dr. Perret, he first described phantom limb pain in 17th century. He had diagnosed it in King Charles the IX. Dr. Odier described the sensitive nodule at the distal end of a transected nerve. Dr. Wood was the first to discuss what a neuroma is. Virchow was the first reported case of a median neuroma, whereas Dr. Kajal and Ramon talked about histology of regeneration, and in Germany, Dr. Wilhelm described total wrist denervation. My mentor, Dr. Dellin, has numerous descriptions of models of peripheral nerve compression, and his student, who now is one of the forefront leaders, Susan McKinnon, did the first human nerve transplant. Thank you very much for your time, and hopefully this was an enjoyable lecture.